Good afternoon. On behalf of the Sri Lankan Association of Geriatric Medicine, let me warmly welcome you, all of you, for the monthly CME. Today we have Dr. Sithira Senivaratna, our first consultant geriatrician to be board certified in this country, and he is serving as the consultant geriatrician in the National Hospital of Sri Lanka. He's a proud product of Faculty of Medicine, University of Colombo, and he obtained his MD in geriatric medicine, MRCP UK, MRCP geriatric medicine, and he completed his training and came back. He's going to talk about a very unusual topic, dysphagia in older adults, which is very timely and some maybe an aspect that we don't usually think about. So I would warmly welcome the online participants as well. Over to you, Sylvia.
Thank you very much for the kind introduction. So just for the online participants, I'm trying to make it full screen. It's not working. Right. Is it all right now? It doesn't tell you. I'm quite sure that possibly.
With 3 dots. Okay. Yeah, that should be fine.
Great. All right, thank you. So, dysphagia in old adults is the topic we are going to discuss today. Do you think dysphagia is a common problem you encounter in your day-to-day clinical practice? Common thing? How common is it? Very common. So I think it's a very common problem. We might sometimes when we talk about dysphagia in old adults, first thing that comes to our mind is sometimes malignancy, right? So people with malignancy presenting with cachexia and having some esophageal type of dysphagia. That's the first thing that comes to our mind. But so if I ask you whether you have seen this type of a patient, so you might get a better idea about what dysphagia is. Right? Just look at the case study to stimulate your minds. 75-year-old male with long-standing diabetes, high blood pressure, presented with cough, sputum, and confusion, signs of a chest infection. And apparently it seems like this is the second chest infection he got over the last 6 months. And he also reports some symptoms like weight loss and some nutritional problems. And the investigation revealed a bacterial infection. And this patient is not tolerating oral feed. So the board staff decided to go ahead with NG. So do you see a lot of older people who are on NG in your day-to-day practice? Yeah, so that those are patients who can't swallow. That's why we have to go with NG. So we are talking about this type of patients, older patients who are unable to tolerate oral feeds, probably when they are acutely ill. Right? And if you look at the prevalence of dysphagia, so there have been a lot of studies done, but not unfortunately in our setting. And in the community treating old adults, this problem can vary from 15% to 30%. So it's quite a huge percentage of old population is having solving difficulties. But when it comes to hospitalized old adults, it is even higher. And when it comes to nursing home residents, usually the patients who go to these type of patients, they can have dysphagia. Half of them can have dysphagia. It can go up to 50%. Sorry, there's some problem with the... There's some technical issue. Just pardon for... Right, okay. Yes, yeah, all right. So going back to the case study, yeah. Okay, sorry about that delay. Yeah, so going back to the case study, so this is about a 75-year-old male with long-standing type 2 diabetes and high blood pressure who presented the features of chest infection. And I'm sure you might have seen these type of patients who are, when they are acutely ill, they are not able to tolerate oral feeds. So we have to go for NG feeds sometimes. So this is called the oral dysfunction, which we are going to discuss today. And when it comes to prevalence, so we were discussing that this very prevalent, I mean, about can go up to 30% in community living old adults. And, when it comes to hospitalized adults, it can be even higher. And talking about patients who are in nursing homes who are much frail and multimorbid, this oral dysfunction can go up to 50%. And when it comes to dementia, and there are several stages of dementia, especially if patients are having advanced type of dementia, this can even go up to 85%. So almost most of the people with advanced dementia has this problem of solving dysfunction. And so today we are going to see what are the underneath reasons. So this is the reason why we are discussing geriatric medicine. So as you can see, the fraction of older population is going up in our country. And by the end of 2025, we are reaching about 20% of our older population being more than 60. So this trend is going to be higher. So everyone need to know about geriatric medicine. And the classical geriatric giants. So these are the main geriatric syndromes we are focusing a lot in geriatric population. So the classical giants are falls and difficulty in mobilizing and problems related to drugs and incontinence and delirium, dementia. And there are new geriatric giants coming up, which are social isolation and impaired homeostasis, so frailty. And impaired swallowing is going to be the next geriatric giant. So it's so common that it seems to be a huge problem in older adults. So why do older people develop swallowing dysfunction? So before digging into the topic, so I'm going to show you the stages of swallowing. So let's recap some anatomy and physiology. So if you look at the swallowing reflex, so as you can see, it has 4 phases. So firstly, our oral cavity, we prepare the fluid, the food bolus, we call it a preparatory phase. Then with our tongue, we do propulsion of the food bolus towards the pharynx. We call it propulsion phase. Then we have the pharyngeal phase, where the pharyngeal muscles will constrict and put the bolus towards the esophagus when the epiglottis is going to be closed. And the esophageal phase, it will move towards the stomach. So those are the 4 phases, as you can see: the oral preparatory, propulsive, pharyngeal, and esophageal phases. When it comes to the neurophysiological circuit of swallowing, it's one of the most complex reflexes in our body. As you can see, there are a lot of cranial nerves involving in the sensory input, as well as so many cranial nerves involved in the motor part as well. So it's a quite complex reflex, and if there's anything go wrong with any of these nerves, muscles, neuromuscular junction, it can result in swallowing impairment. Right. When we categorize dysphagia in a clinical context, we discuss about these 2 things. It could be oropharyngeal dysphagia, or it could be esophageal dysphagia. So as now you saw in the swallowing reflex, there are 4 phases. So if there's a problem with the oropharyngeal phase, we call it oropharyngeal dysphagia. But if there's a problem with esophageal phase, we call it esophageal dysphagia. Simple enough. So today I am going to focus more on oropharyngeal dysphagia. So let's first discuss esophageal dysphagia and finish it off. Right. So if a patient present with these type of symptoms, if they come to you with, complaining food often gets stuck in your chest, and so this sounds more like a esophageal type of dysphagia. And sometimes this dysphagia can be more for solids, and sometimes this can be more for liquids. If it is more for solids, it indicates a mechanical type of obstruction. And if mechanical type of obstruction can lead to a severe obstruction, even, swallowing liquids can be difficult. And if it is more towards liquids, we are dealing with something to do with neuromuscular something, all right? So a motor dysfunction. And it's important to establish the progression of symptoms and look into the associated symptoms to understand what is the underlying pathology that causing esophageal type of dysphagia. So if you look at this chart, you can see there are a huge amount of risk factors that can lead to esophageal type of dysphagia. Some of these can be, intrinsic problems inside the esophagus, such as malignancies, strictures. These strictures can be due to peptic ulcers, can be due to drugs like doxycycline, alendronic acid, and can be due to extrinsic problems like extrinsic compression due to some other nearby cancers, or it can be due to cardiac enlargement causing dysphagia, and there can be mobility problems as well. So if you suspect this type of dysphagia, so what's the next step? We usually refer to a gastroenterologist or a GI surgeon to get upper GI endoscopy done. And depending on the findings, probably, then we might need to go ahead with other investigations like esophageal manometry, barium swallow, pH monitoring, and so and then, if the cause found, then we treat the cause. So this is about esophageal type of dysphagia. But most of the patients, they have the other type of dysphagia when it comes to older adults, which is called oropharyngeal dysphagia. So how do oropharyngeal dysphagia patients present? So the main symptoms are, so they have this difficulty in initiating a swallow rather than food getting stuck in chest. And often, because during the pharyngeal phase, we need to coordinate the approach of the epiglottis, most of these patients complain of cough. And if it is associated with neuromuscular problems, most often patients present with nasal regurgitation as well sometimes. And 1/3 of these aspirations can go without cough, can be silent aspiration. And if some older person presenting with recurrent aspiration pneumonia, even without choking, coughing, we need to suspect silent aspiration, which can present as that's a one way of oropharyngeal dysphagia can present to you. All right. So again, looking at the causes of the oropharyngeal dysphagia, as you can see, there's a huge list. Some problems are iatrogenic, and medications like, especially the anticholinergic medications, which can cause dry mouth, and chemotherapy, neuroleptics, they can affect the neuromuscular coordination and can cause oropharyngeal type of dysphagia. So some rare infections can cause mucositis, and there are some metabolic problems, and huge list of neurological causes, including the most common cause is dementia, and the other problems like Parkinson's disease can cause oropharyngeal type of dysphagia. Not to forget about the muscle causes of dysphagia, and then structural causes of dysphagia. As you can see, there are a lot of pathological causes of dysphagia. When it comes to old adults, these patients can have some these type of pathological problem, but most of these patients are having dysphagia due to multifactorial etiology. So if you know about the other geriatric syndromes like falls, delirium, urinary incontinence, immobility, the geriatric syndromes are multifactorial. That's the nature of geriatric syndromes. When it comes to dysphagia in old age, again, it's multifactorial. So it's an interplay between age-related physiological changes in our body, as well as chronic diseases and the medication patient is taking, and the nutritional deficiencies contribute, as well as age-related muscle weakness, we call it sarcopenia, and also, as you can see, the cognition plays a major role. This is quite a complex reflex, reflexes. So cognitive impairment can also have a role to play in dysphagia. Right. What is presbyphagia? So presbyphagia by definition is age-related swallowing dysfunction. All right. So these patients mostly they are asymptomatic. They don't come with aspiration pneumonia. They don't come with choking. So what are the physiological changes that can happen which leads to oral dysfunction? So as we discussed earlier, with age, our skeletal muscle mass goes down. We call it sarcopenia. So it's not only the muscles in the arms and legs, but also the skeletal muscles in the pharynx also affected. So reduced muscle function can contribute to dysphagia, and reduction in elasticity of the connective tissues can contribute to dysphagia. And there can be some cervical neck problems, cervical spinal problems, and the dry mouth seems to be a common problem in old age, which is mostly affected by the medications, especially the anticholinergics, can contribute to solving dysfunction in old age. And also the reduced taste sensitivity and reduced olfactory sensitivity. As if you can remember this complex reflex of the swallowing, vision and olfactory sensation also has a role to play, and taste also has a role to play. And if taste and olfactory sensations are going down, so it can also contribute to solving dysfunction in old adults. So just in a diagram to show you again, as you can see, the olfactory, taste, these functions go down, and the dentition goes down, muscle function goes down, saliva goes down, tissue elasticity, as well as there are skeletal changes, as well as problems with the brain, which can contribute to this swallowing dysfunction called presbyophagia. And as I told earlier, this is usually asymptomatic. And if you assess the swallowing function, it can be normal or can be mildly affected, but at a subclinical level. And these patients usually spend a long time to eat meals than usual, and they might be having some problem with phonation. And sometimes there could be subtle manifestations like post-swallow residue, chewing difficulties. And when they are acutely ill, they develop dysphagia. So I was talking about sarcopenia, the previous slide. So as you can see, sarcopenia is age-related muscle loss as well as reduced muscle function. So this is the cross-section of a thigh muscle, if you can see, with age. This is 31-year-old male. And as you can see, compared with 31 years, this gentleman in 80s, the muscles are replaced by fat. Right? So this is called sarcopenia. And this is not only affecting to the muscles in your limbs, but also the pharynx. We call it another entity called oral sarcopenia. So, and this is called sarcopenic dysphagia. So as you can see, malnutrition, as well as problems with the buccal cavity, generalized sarcopenia, all can be interrelated, and all sarcopenic dysphagia can lead to nutrition problems and lead to bone problems as well as swallowing dysfunction. Right. So how do you diagnose sarcopenic dysphagia? So there's a consensus diagnostic criteria, and so if somebody is presenting with clinical manifestations of dysphagia, you don't have to use a tool, but as a screening, if you're not quite sure, you can use a tool to assess whether the patient is having dysphagia. And patient should be having evidence of generalized sarcopenia. And if you have facilities, you can do some imaging and to see the muscle mass, which we don't usually do. And then other pathological cause of dysphagia has to be excluded, as I described in my previous slides. And then if you have done all these steps, the main cause of dysphagia is considered to be sarcopenia. So if you look at this diagnostic algorithm, the same things. So how do you assess sarcopenia in clinical practice? We usually use hand grip strength using a something called a handheld dynamometer. Usually, if your body skeletal muscle function goes down, your hand grip strength goes down. Right? People find it difficult to open bottles. Right? So we can measure the hand grip strength clinically using something called a handheld dynamometer. So if a handheld dynamometer shows you reduced hand grip strength, that's an evidence of sarcopenia. See, there are some other tests like we sometimes use gait speed as a measure. We do a test called chair rise test to see whether the patient is having reduced lower limb muscle strength. So these type of tests can be used in clinical practice to diagnose sarcopenia. So if they have sarcopenia, then we can image and see whether the masses are low using either DEXA scan or CT scan, but usually we don't practice in our clinical practice. And if patient is having swallowing dysfunction, then we can, if we can assess the swallowing muscle strength, we can reliably diagnose sarcopenia, but we need to have a tongue pressure measurement to be able to get a tongue pressure measurement to diagnose that, but we don't have this facility. So without that, we can diagnose possible sarcopenic dysphagia. So that's how we do, right? Right. And there's another concept called oral frailty, right? So I'm quite sure you are familiar with this concept of frailty. So frailty is reduced physiological reserve in old age, making someone more vulnerable to external stressors, all right? So when it comes to oral cavity, we discuss about something called oral frailty, right? So as I discussed earlier, so these people who are in the community might be having some subclinical problems with swallowing dysfunction, but when they are acutely ill, they get this swallowing dysfunction because their functional results have been quite low, right? So this is recognized as oral frailty. So it's a very important concept. So as you can see, there are a lot of contributors to oral frailty, and I will go mainly the oral frailty leads to a lot of other problems like physical frailty as well as disability. So as you can see, if someone is frail, so the swallowing dysfunction can be subclinical. But when there's acute stressor, they can develop oral hyperfunction and also lead to oral dysfunction. And so this is a very nice article to read if you're interested more about oral frailty. And this oral frailty, has a lot of contributors, including the age-related problems, as well as there are contributors from multimorbidity and also the medications, right? So to screen oral frailty is very important because we don't wait until someone develops swallowing dysfunction and aspiration pneumonia to diagnose dysphagia. So how do you screen for oral frailty? If someone is more than 60 years and we can when you see your patients in day-to-day clinics, you can use these simple tools to see whether they have oral dysfunction. So this is a tool we use in our geriatric clinic. So this is called oral frailty 8 index. And these are the things we usually ask. Any difficulties eating tough foods, and whether they have choked any tea or soups, and whether they have dentures, and whether they have dry mouth, and then whether they have impaired mobility, and as you can see, they might be having difficulty in eating hard foods, right? So and oral hygiene is also very important. So these type of list of questions are there. So if someone is having two, I mean less than three, right, risk factors, we consider them as robust. If they have three, we call them pre-frail. Four or more, we call them having oral frailty. So another important score is this one, oral frailty index 5, very easy to use. So simple things like having fever teeth, difficulty in chewing, difficulty in swallowing, dry mouth, and low articulative or motor skills. So if someone is having these problems, there's electronic calculator as well. So you can use electronic calculator and see whether they have either suspected oral high. And this correlates with physical frailty. Right? If you see somebody frail, losing weight, having falls, memory impairment, all right, don't forget to screen for oral frailty because this can be a killer. They can present with aspiration pneumonia, and most of the older adults die with aspiration pneumonias, if you have seen. So if you consider about the physical frailty, so this chart we are familiar with. So this is the difference between a fit older person and a frail older person. So fit older person, when they have minor illness, their functional baseline goes down, but they return back to normal quite soon. But when it comes to a frail old adult, what is the difference? So their functional level goes down a lot, and it takes a long time to recover, and most often they don't come back to their baseline. So this is not only for the physical frailty, but it's also true for oral frailty as well. So people who have this oral hyperfunction, they can develop oral dysfunction. People with oral frailty, they can develop oral hyperfunction, dysfunction when they are acutely ill, right? So I think now it's quite clear about the oral hyperfunction in old age. All right. So let's move to the evaluation and management of this common problem. Right. So what are the warning signs of dysphagia? So most of the things we have already discussed, but if somebody is having reduced alertness and cognitive dysfunction, don't forget to screen for oral frailty and hyperfunction, because in these slides, 85% of patients with dementia can have solving dysfunction, right? And what are the manifestations of impaired or pharyngeal functions? They can have, they can, directly tell that I have difficulty in swallowing, and sometimes they can have a sense of obstruction in my throat. And these patients can present with drooling because they can't swallow saliva. And sometimes these people can have weight loss unintentionally, but if you ask about swallowing, they don't have major complaints of swallowing. But over time, their food intake has gone down because of oral dysfunction, and they present with weight loss. And I was talking about the silent aspiration. So recurrent chest infections, don't forget to assess the swallowing. So because 1/3 of chest infections, they are due to silent aspiration. There might not be any evidence of choking. And they can have some impaired breathing immediately, or even after 30 minutes after meals, right? And pain on swallowing can be another presentation of dysphagia. So if you're not quite sure whether this patient is having dysphagia or not, you can use a tool. So what are the tools? So we have several tools. So E10 is a common tool that can be used for screen for solving dysfunctions, and there are some other assessment methods. So this is Toronto bedside solving assessment. We use 10 spoons of water and see how patient tolerates the tolerates water, whether they develop cough during or after swallowing the water. And gagging swallowing screen test is another one, and a similar one actually. And the volume viscosity swallowing test, where we use several different thickened fluids to assess whether the patient is having difficulty in swallowing. So if they have the swallowing difficulty clinically, or if they have any positive score in these screening tools, we can get a speech therapist to do a proper assessment in this patient. These are just screening tools. If somebody is having evidence of solving dysfunction, we have to get a specialist, speech therapist, to get a proper assessment of this patient's solving. Right. So when it comes to instrumental examination, we have this video fluoroscopic swallow study. So this is kind of a dynamic X-ray study where we give a patient like this, like in this picture, some barium, right? Barium, and ask them to swallow it. And we get serial X-rays and look at the barium bolus, right? So you might see this coming to the pharynx and going to the esophagus. And in some people, even after solving, they will have some residues in the pharyngeal area, pharyngeal recess area. They will have some residues. Some people, you might see the barium going to the airway, right? So it's a good way of assessing solving dysfunction. We call it video fluoroscopic swallow study. But it will be a bit difficult to do this thing for a patient who is acutely ill, or a patient who is having cognitive impairment, who can't follow the commands. And there's a radiation as well, and you have to mobilize this patient. You can't do it in the at bedside. You have to take him to the radiology department to get this done. And there's another one called fiber optic endoscopic evaluation of swallowing, where you just like in this one, put an endoscope through the nostril and directly visualize the pharynx. And then you can give either water, a thickened fluid, you can give even normal food to eat, and then you can observe what's happening to this food, whether it's getting accumulated in the pharynx, whether it's going to the airway, whether it's correctly going to the esophagus, whether they have any residue left after swallowing. So you can directly visualize. So that's the advantage of this. So even for patients with dementia, right, you can give something to eat, and if you can place the endoscopy, you can see what happened to the weight. There's no radiation, and if you have facility, even bedside, you can do this. You don't have to get the patient to the radiology department to get this done. All right. So we discussed about screening for swallowing and get a speech therapist to do the clinical assessment. Then if you want to get more details about swallowing, we can get ENT team to perform this VFSS or fees, right? Right. And it's also important to do a thing called comprehensive geriatric assessment. So this is the tool a geriatrician will use to assess a patient holistically. So as you can see, so no geriatric syndromes is isolated. Everything is connected. So cognitive impairment, falls, fractures, incontinence, functional impairment, nutritional impairment, they all are linked to dysphagia. So as you can see, if you have dysphagia, there's a decreased oral intake, malnutrition, which leads to sarcopenia, frailty, and falls and fractures. So it's important to understand the patient holistically. So for that, we use something called a comprehensive geriatric assessment, where we assess patient's functional capacity, social circumstances, medical problems, mental problems, environment, everything. So these are few things which are related to the dysphagia in CGA. So any acute illness, any comorbid diseases, any evidence of medications which can cause dysphagia, and changes in special senses as we discussed earlier, vision, olfactory taste, everything can affect swallowing. And nutrition assessment is mandatory to see whether there's any complications of swallowing dysfunction, as well as nutrition, how many the patient is having, and then sarcopenic dysphagia, we need to assess patients' sarcopenia and their cognition, how their mood is. Probably these patients are unable to have good meal, and then maybe they are depressed, and need to do a functional assessment, their social support, and advanced care planning. Everything is important in a patient with dysphagia. Right. So these are some medications which can cause swallowing dysfunction. So as you can see, these things are not simple. They need thorough assessment. So if your patient is on multiple these medications which can cause dry mouth, that can be the male culprit. All right. So screen for the medications. All right. So the medications, and if they have these type of problems, de-prescribe. So anticholinergics are older patients' enemy. All right. Always screen for anticholinergics, and if they have anticholinergic drugs, do de-prescribing. All right, need to de-prescribe. What are the consequences of dysphagia? So as we discussed, several times now, it can lead to dehydration and malnutrition. Right, and it can lead to aspiration pneumonia. It can worsen sarcopenia and frailty. And not only the physical, it can cause psychological problems like depression, as well as reduced quality of life, and it finally leading to functional problems, and they might have some social implications due to dysphagia as well. All right. So how do you treat dysphagia? Now, firstly, if you have found a cause, treat the cause. For example, this patient is having evidence of sarcopenic dysphagia, nutritional interventions might improve swallowing. So giving high protein diet, giving whey protein will improve. If there's something reversible, treat the cause. And then sometimes the cause might not be apparent. Patient might be still having oral hyperfunction, and so treatment of dysphagia itself is also very important. So how do you treat dysphagia? So there are some compensatory treatments you can do which will have an immediate benefit. For example, for these patients who are having risk of aspiration, we ask them to do certain postural adjustments, sit them at 90 degrees, even 30 minutes after the meal, right? Because as I discussed earlier, sometimes this food can get accumulated in your throat, right? So even 30 minutes after the meal, you have to make them sit up 90 degrees, right? And there are some swallowing maneuvers which we will discuss in a while, and we can do some dietary modifications which also we will discuss in a while. Then who is the other important person in the team? Speech and language therapist. All right, we have to get speech and language therapist on board and get them to do some good rehabilitation exercises on these patients. All right, and that really helps solving dysfunction in old people. And then we need to advise them on other eating lifestyle modifications. What are the good eating style modifications that can prevent aspiration in a person with oral dysfunction? We ask them to eat slow, right? Take your time, eat slow, and take small amount of food or liquid in mouth at a time. Don't eat a lot at a time, all right? And use, sometimes we ask them to use a lot of gravy and facilitate fluid bolus formation. Don't eat dry stuff, right? And eating crumbly dry foods can cause more aspiration. And also, if you mix food with different textures in the same mouthful, that can increase aspiration, all right? And then, especially for patients with dual tasking, we advise not to do dual, with the cognitive impairment, we advise not to do dual tasking. People watch television while eating, right? And they aspirate, right? So, because if your cognitive abilities are, little bit, you might not be able to do dual tasking. Focus on food. when you are eating, take your time, all right? Use appropriate texture, all right? Okay, very important to have good oral hygiene. So why? So most of these patients, they get aspiration pneumonia not because of food. They aspirate their own saliva, right? And also you can have food residues in your mouth after swallowing. So these things can cause silent aspiration. So for people who we can't sometimes do anything, we can advise them to brush twice a day, right? And use mouthwash to keep the oral cavity clean. So that will prevent aspiration pneumonia. Very important and forgotten advice to give. So this is how you optimize the positioning during meal time. Upright positioning, good chair is important, right? Feet supported, good table, right? And supervised meal time and slow eating, right? Important lifestyle modifications. And sometimes we use these type of swallowing manuals. One thing is chin tuck swallow, right? If you have difficulty in swallowing, I mean, if you have problems with aspiration, we ask the people to get, when especially these people have problems when they are swallowing, very thin fluids like water. They find it difficult to make a bolus out of thin fluid. They get dispersed in the oral cavity, all right? We ask them to take a fluid bolus, right? Then press your chin against your chest, then you know what happens, this airway, it get narrowed, and then swallow it. So there's a less risk of water going in the wrong way, all right? It's a very simple advices, right? So what is supraglottic swallow? So people who get frequent choking, we ask them to get the fluid in the mouth, take a deep breath through the nostrils, and then swallow, and then cough just after you swallow, right? If there's any aspirate, just to puff it out, right? Supraglottic swallow. And there are some other manuals like Mendelssohn manual, where we ask the older person to keep the fingers on the laryngeal area. When you swallow, the larynx moves up, right? Yes, right. And it helps the epiglottis closure, so and prevent aspiration. And if we ask them to do effortful swallow, right? So enhance tongue-based retraction and pharyngeal clearance. So we ask them to press the tongue, right? This can be used as exercise as well, all right? So press the tongue against the hard palate, right? And then swallow as hard as you can, all right? So this improves patient's muscle function, all right? You need to have good cognitive abilities to do these things. And this Masako maneuver is another one, right? Which strengthen pharyngeal constrictors, right? So this is used as exercise actually. We ask them to put the tongue out, keep them in between your teeth, and then swallow saliva, all right? So you can do this as exercise. When you do that, you're swallowing, strengthen the pharyngeal constrictors to get much more strengthened, all right? Okay. And these are called shaker exercises. Ask them to lie down flat and raise the head. And these, as you can see, the tongue muscles, the pharyngeal muscles, they will become strengthened. So we can put them into a rehabilitation, process with the help of a speech therapist. And they have, depending on patient risk factors, we can have a personalized rehabilitation process for this patient with oral dysfunction, focusing on their lips, focusing on their mouth opening, focusing on their tongue and other areas in the mouth. Right? So it's called rehabilitation. So like a patient with paralysis, we do rehabilitation. So patient with poor oral function, we can do rehabilitation like this. All right. So this is about rehabilitating a patient. So what about and diet? All right. Familiar with this one? This is called IDSI framework, food classification. All right. So depending how thick a fluid is, we can categorize them from 0 to 4. All right. 0 is very thin fluid like water. All right. 4 is very fluid like something. The fluid is not able to go through the slits of the fork. This is a very thick fluid, right? So so if you go up in this classification, your fluid gets more thicker and thicker. And when it comes to food, if you are considering here 7 is hard food, and you can make them soft and moist, and you can reduce the bite size. Right? Basically, you blend the food. All right. So we can get it down from 7 to 3. So people with swallowing difficulties, what type of fluid they can't drink? What do you think? Can they drink easily level 0 or level 4? For the people who think level 0, level 4. Yeah, so people find it easy to drink level 4 because it's easier to make a bolus. All right. So level 0 water, it's very difficult to drink because it get dispersed. You can make a bolus out of water. All right. So it's a high chance of aspiration. We have seen people, choking on water a lot, right? But if you give a thicker one, they might not. All right. And which type of food they find it difficult to swallow? Hard ones or minced moist blended one? Hard ones again difficult to swallow, but minced moist soft ones they find it easy to swallow. All right. And the problem is when you give thickened fluid, sometimes the thirst might not go away. All right. People might not like to have it for a long term. That's why we need to sometimes go ahead with these maneuvers and try to give them some water. All right. And remember, for patients who can't swallow, when you start, hydrating them, 1 cup of jelly is equivalent to 1 cup of water. All right. So you can use a lot of jelly or jelly thicken anything as thick as jelly. Right? So good way of swallowing. And how do you thicken the fluids? So there are commercial prepared thickeners, and they advise fluid thicken up to IDDS I 1 2 3 4 likewise. So if you use 6 scoops of this thickener, it brings the water into level 4 thickness. But we don't have thickeners, so we use things like gelatin and corn flour to thicken the fluid. Right? Okay. So that's how we modify the diet. All right. So last part of the talk about feeding problems, I'm focusing mainly on the dysphagia in people with dementia. All right. So as we discussed earlier, 85% of people with dementia can have swallowing dysfunction. And it's not only the swallowing dysfunction, but there are a lot of problems. When it comes to feeding a dementia patient, there are lot of other barriers. This can be related to their cognitive decline, this can be related to their behavioral changes, and can be directly related to their underlying, dementia type and pathology. And also, as we discussed earlier, there are age-related changes. So I'm not going into every detail in this slide. And so this can be a, quite a complicated thing. And when it comes to dysphagia, so mainly we are worried about the oropharyngeal type of dysphagia, and this can lead to aspiration pneumonia. And what are the factors affecting dysphagia? So attention deficits, you need to have a good attention, to do this swallowing function. If you have poor attention, that can impair your swallowing. And initiation and orientation, there can be problems, right? Then executive function, there can be problems. So everything related to cognitive decline in dementia. And the recognition of food, there can be problems. And apraxia will be a problem when it comes to swallowing. They might not remember how to swallow, right? If the food is presented to their mouth, right? So we also use some specialized assessments like dementia mealtime assessment tool and Edinburgh feeding evaluation and dementia questionnaire, and the MAN assessment swallowing ability test for patients with dementia to assess their swallowing and oral dysfunction. How do you manage dysphagia? So you can manage dysphagia alone in these patients because it comes with a lot of other problems in feeding, right? So optimizing environment is quite important. So dementia people, they eat well in calm and relaxing atmosphere, right? So if they have a lot of sounds coming, and they might distract quite easily, right? But creating a familiar environment is also very important. Might stimulate the appetite. So, in some studies they have seen, so the sound of the kettle, will stimulate a dementia patient to have tea. Right? The whistling sound of the kettle will stimulate them to have some tea. So creating a friendly environment is quite important. And things like having good seating, avoiding clutter, and presenting the meal in a very simple way rather than a very disorganized way in the plate will enhance the ability to eat. And we need to always encourage independent eating. So, if they might be having hand dysfunctions, we have, make, make the handle easy to grip. We can use these type of things to attach the utensils to the hands. And sometimes we use these methods, we call them hand over assistance. And we try to encourage the dementia patient to get their mouth to get their hand to their mouth. So that will also stimulate the swallowing reflex. If you give directly feed them, it might not activate the swallowing reflex. But if you get their hand and get them to eat themselves, that will activate the swallowing reflex. So hand over hand assistance is very important, right? As I discussed earlier, you need to remove clutter from the plate and always encourage self-feeding. And if there are underlying problems like dental problems, so they might not come out with these problems because they are cognitively impaired. You have to actively look for these problems. Can be not the people who are eating well, sometimes they suddenly stop, right? So there can be some reversible problem like maybe a dental caries, right? There may be some ulcer in the mouth, and there may be delirium because of some other cause like constipation, urinary tract infection. So you have to always manage the underlying cause. And it's very important to give mealtime assistance for these patients. So we can't rush feeding a elderly patient with dementia. Sometimes it takes about 45 minutes to feed a person. All right, this is like feeding children. All right, you have to have patience, and the carer has to have special training. Sit with the person. Then with time, they can understand what patient's preferences are, and with the careful monitoring, we can do a good job. Right. So again, same principles apply when we talk about management of patients with dementia with swallowing difficulty, diet modifications, and feeding techniques. So as I discussed earlier, having good oral hygiene is very important to prevent aspiration pneumonia, right? And then comes the alternative feeding methods, right? About tube feeding, right? So when it comes to the alternative feeding methods, it's a very important area which we need to discuss. So we have to think about, nasogastric tube and then PEG tube. All right. So what do you think about nasogastric tube? Can you use nasogastric tube for permanent feeding? You can't use, right? It's only for temporary use. So what are the problems with nasogastric tube? It's a comfortable procedure. A very uncomfortable procedure. All right. So nose is a very sensitive part of your body. When you put a tube through the nose, it's a very painful procedure. So that's why people take it out. If it's a comfortable procedure, they will not bothered about it, right? But people often take it out because it's really uncomfortable. And what about the risk of aspiration with NG tube? What about the risk of aspiration? Does it go down or does it go up with NG tube? Go up, yes, yeah. It's a, and sometimes people think aspiration risk will go down with NG tube, but actually it goes up with NG tube because this NG goes with in your throat near your epiglottis, and this epiglottic closure reflex will get affected, right? So epiglottis closure will not be there. They can aspirate their own secretions much more. So incidence of aspiration is much more with NG tube. What is the advantage of NG? You can give as much as you want. That's the advantage you have with NG. But the other side, downside, it is an uncomfortable procedure and it increases the risk of aspiration. All right. So if you are looking at a patient who has oral hyperfunction due to dementia, which is irreversible, so you can't keep NG tube forever, right? So you need to either think about modifying diet and treat some reversible causes and get back to do some oral feeding, or you need to think about peg feeding, right? Especially when it comes to advanced dementia, right? People at some stage of dementia, they lose the ability to swallow. Right? It's a very sensitive time actually, right? So by this time, most of the patients, they are not able to recognize their family members. They are completely dependent for their ADS, right? So cognition has gone down quite a lot, and at some stage they develop this swallowing dysfunction. When that happens, so it seems like it's an irreversible type of thing. And what about putting a PEG tube? Is it a good thing or a bad thing? A very difficult decision actually, because pig feeding can be sometimes it can be harmful, all right? And don't forget, even though it's a very simple procedure, these frail older people with multiple morbidities, nutritional problems, cognitive impairment can have some risk of mortality even following pective insertion. So we always encourage to do some risk scoring, right? We can use Sheffield gastrostomy score, and we can use Royal Free Hospital gastrostomy score, just to see whether they have, how much risk they have, to develop a complication following pective insertion. Right? It's not a very simple decision. And when it comes to advanced dementia, there are a lot of research to say it's a harmful thing, right? So pective is a harmful thing, and it reduces the quality of life. So what are the advantages of pective? So these are the potential risks related to the pective. It can cause some local problems like pain, and it can cause, sometimes pec leakage and exfoliation of the skin. Pective can get blocked, all right? And people can get the pective out because the dementia patients, they don't know what's there in their tummy, right? For them, it's something poking in the tummy, so they try to take it out. So what do? We have to restrict them, either pharmacologically or physically. So that's not a good quality of life. We are going to feed them but restrict them. So it doesn't make any sense, right? So there are a lot of problems with pective. And it's a very good read, actually, if you want to read about feeding tubes in patients with severe dementia. So in patients with severe dementia, getting a peg tube in, so we have certain expectations. So one expectation is, with peg feeding, we can increase their nutrition, right? So who think with peg feeding we can increase a patient's nutrition with advanced dementia? Because we can give a lot. What happens to the... But actually studies have shown, even with peg feeding, these patients tend to have weight loss, right? Because in advanced dementia there are so many other reasons. They are in kind of a catabolic state. So there's no clear evidence to say they get weight gain, all right? And what about aspiration? Does pective reduce risk of aspiration? Actually, this feed we give from pective, they can regurgitate and they can aspirate, as well as they can aspirate their own secretions. So that's the main culprit, right? So aspiration risk doesn't change with peg feeding, right? So peg doesn't reduce aspiration, peg doesn't improve nutrition. Does peg increase overall survival? It doesn't increase overall survival, because these patients, advanced dementia, they have a irreversible neurological problems, and they develop dysphagia as a part of this progressive irreversible neurological problems. They are in a kind of a end of life situation, all right? So artificially feeding them with pective will not prolong their lifespan, right? So there are a lot of evidence against pective, all right? And as we discussed, peg can cause a lot of discomfort, blockage, and can leak, can cause a lot of care anxiety, right? And you need to tie the patient. So overall, it reduces the quality of life. In advanced dementia patients, we don't encourage peg insertion. So as you can see, this is a trajectory we see for patients with frailty and dementia. So as you can see, there's a gradual functional decline, and they finally, reach there, and they develop swallowing difficulty most of the time towards the end. All right, so I think we have come to the last bits of the day. Just to show you a few quick case discussions. This is an 80-year-old patient with diagnosed with vascular dementia, admitted for chest infection, and this patient was previously independent for activities of daily living. And last 3 days, patient is more confused, and patient had difficulty in swallowing, and he also had cough. All right, seems like patient is also having drooling of saliva and frequent cough. But previously, patient had no problems with swallowing. Now, for last 3 days only, even though patient is diagnosed with dementia, only for last 3 days, patient is having these swallowing problems and drooling of saliva, which is a bit uncommon. So we went ahead we put the NG tube until we evaluate this patient, and there's an element of delirium. We treated with IV antibiotics to treat the infection which has caused delirium, and carried MRI brain because it's a quite acute onset, and patient had a pontine infarction. So even in dementia patients, they can be reversible causes. All right. And case study 2, this patient was a 90-year-old lady and who presented with aspiration pneumonia, and the dementia was there for 10 years, and currently completely dependent for basic activities of daily living. And it seems like she has had solving difficulty for last 6 months. And then NG was inserted. These are real life case scenarios. And IV antibiotics started. Then we get the speech and language therapist on board who will facilitate taking this type of difficult decision. Then, discuss with the family about pet tube. I mean, this seems to be something irreversible because this is a progressive neurological disorder. Patient has solving difficult for last 6 months. So family was requesting a peg tube. So we discussed the risks of peg tube, and sometimes we might have to do certain things according to family speech, which is sometimes not correct, but sometimes we have to listen to the families as well. And this patient, was started on peg tube, and patient was able to survive because we were giving nutrition through the peg, but patient developed a grade 4 bed sore and then died in 1 month time. So even though sometimes in some selected cases with peg tube, you are able to lengthen the life, the quality of life during that period will be quite low. And people, sometimes come back after many years and tell, my mother has not improved after peg insertion, but we are giving feeding every 3 hours, and she's in the bed, she's not responding, but she's not developing any complications, which is sometimes a bit frustrating. And sometimes these people develop very large bed sore, and they die in a very difficult way. Right. So this again a patient who had multimorbidity. We referred to geriatric unit, and patient had clear functional decline, and patient we didn't encourage PIC, but anyway after difficult discussion, PIC was inserted. Patient passed away in 2 weeks. And there's another patient with, so I will skip that one for the interest of time. And 87-year-old patient with advanced dementia and presenting with recurrent aspiration pneumonia. And patient was NG for last 6 weeks, but patient is pulling the NG out. And now family is worried, the NG is not comfortable. That's why she is pulling it out. So they were against putting NG again, and they discussed about risks of NG, and families, agreed not to go ahead with even peg tube. So we agreed to do comfort feeding for this patient as much as they tolerate with modified diet, hand feeding. So that's the way. And we made an advanced care planning onto what degree we are going to treat them when they get a chest infection, because aspiration is something we expect in future. Right. That's the end of my lecture. I'm happy to answer any questions if you have.
Thank you very much, Dr. Sithira, for that excellent talk. It was very comprehensive, very practical, and also you introduced lots of new concepts to us as well. So the floor is now open for any questions, if the audience has any questions. Okay. In the absence, you got it.
Thank you. One of the speech therapists actually from our meditation research center is planning to do a clinical trial on mindfulness meditation focused on dysphagia management. But I think the patients that category that we are discussing here, one with the cognitive impairment, there be a problem. But for stroke, maybe a younger age group, maybe mindfulness meditation can help us.
Yeah, I think so. Cognition and mindfulness might be playing a huge role in solving. So I expect to have some good result. So we are also conducting research actually at the moment. We are trying to validate the overall fertility index as well as trying to prevalence in hospital patients and relationship with other geriatric syndromes. So we need collaboration with the overall fertility index and all. Thank you.
And Sithira, I have one question for you as well. I think especially when it comes to patients with advanced dementia, and also sometimes even patients without dementia, there is that third option when it comes to swallowing problems. If it's decided that a PEG or NG is needed, the option of risk feeding. So obviously with patients with advanced dementia, that becomes a third option. And sometimes we come across patients who refuse. They've got capacity and they don't want to be NG fed or PEG fed. So in these sort of situations, how would you approach the idea of risk feeding with patients?
I mean, patients have any capacity, then definitely I will restrict patient's capacity and start, some rehabilitation as well as patient life. And if a patient doesn't have capacity, it's a really difficult situation. I do discussions several times. It takes sometimes hours and days, but sometimes still, family wants to go ahead with take decision. So sometimes we have to respect family decision to avoid conflicts.
Thank you very much. So now I would like to invite past president of the Sri Lankan Association of Geriatric Medicine and senior consultant physician, Professor Kamani Surya Madam, as well as President-elect Dr. Shahan Silva, to hand over the certificate of appreciation to Dr. Sithira Senivaratna. Thank you.